um, the need of the mentally impaired, and we've done the need of the physically impaired, and we've done brief on the care and the type of care you need to tap to. So I'll start now. The patient referred to the GP. So what will you do as a GP?
So there's two scenarios. There's the proactive, and I guess there's probably the reactive, which I think probably you see it all. We don't get many of the proactive people actively coming and trying to sort things out in advance of things, of the crisis point coming. So you're probably more likely to come when you notice something off, something different. Usually it may be, there's two probably groups of times, either memory impairment or care needs, complex care needs. So that involves frailty, and it involves perhaps reduced mobility, as well as inability to care for oneself. So one of your gateways through to many of these things is to see the GP. Now, the GP often will signpost you to other services. So where there's complex care needs, the difficulty looking after the needs of mum or dad, because it's become either you've got your own health problems, back problems, difficulty moving them now because they're becoming quite heavy, you're becoming quite weak. So they can signpost you to people like social services. You can apply for additional kind of support at home. And then if there are medical issues, then we can direct you towards whichever specialist or treat it ourselves. So if it's quite simple. But the more proactive you are, the more you can kind of anticipate things in advance. One thing we really like to encourage is people talking about death, proactively having discussions with their family about what good dying looks like, so that your family are aware of what your wishes are, what you would like to happen at the end of your life, and then you get things set up. So you get lasting power of attorney. So there's two you need to bear in mind. So there's one for health and one for finance and one for welfare. So welfare being health. So if you turn up into a hospital and they say, okay, we should do this, and you don't agree with doing this, then your voice will be taken into consideration, but they will do what's in the best interest of the patient, unless you have lasting power of attorney. So essentially, your voice becomes the proxy of the family member. So if you haven't got that in place, and it has to be for welfare, for health, unless you've got that in place, then really there's not that much that you can't override the wishes, the best interest of what's being proposed. So yeah, that's really there's a port of contact really.
Thank you. Now you went to the GP and you have a patient, and it depends on the question. Your question you ask me, a psychiatrist. You could ask the social worker. You could ask the geriatrician. So it's your turn to fire your questions and ask. I think the brother here.
Assalamu alaikum, and thanks very much firstly for putting this presentation together.
Thank you.
And for valuable input from all of you. So,
you had a question for Dr. Mudassar.
The question is, if you have a patient in life, as my mother, she's on number 8 scenario that you and she's been labelled as a palliative care.
Yeah.
What can we as a family do to try and help and do the best possible care for them?
Okay. So, I mean, it will depend on specific needs. So have you got anything specific you want me to answer? Like any specific scenario which you want me to tell you what could you do to help?
We're getting, the carers that's been identified, but as a family, is there anything more we can access to try and give you the best care possible? Because obviously...
Yeah, so I mean, the carers will come only 4 times a day. So if that's what the situation is, she needs 24-hour care.
Yeah.
So you have to fill in the gaps. So there is a lot which you have to still do.
Yeah.
So it's not that what you can do. In fact, you have to.
Yes.
Because they're only like 2 hours in 24 hours,
That's
which
right,
the carers are covering. So you have to cover the rest of the 20 hours.
Yes.
So you have to do. You have to look after her nutrition. You have to move her from positioning from side to side to prevent the pressure ulcer. You have to give her company to mm, from the mood point of view and emotional support point of view. If she's on medication, a lot of times the carers can actually do that because they are in certain times. But if they are having some medication which is more than 4 times a day, or which she needs at the time when the carers are not there, then the family has to come in. So all of these things with family have to do it. So it's not about what you can do; it's actually what you have to do. So unless you have got any specific questions, then
I was
I
thinking
can
because
tell
obviously,
you.
like you said, we love to look after our parents, and it's our
Yeah.
duty, but emotionally it's hard. I
It
just
is.
found, when
Yeah.
my mom is suffering, I find it emotionally hard.
It is.
Providing all the physical and medical care is the easy bit.
Is she demanding? Does she ask?
No, mashallah, she's very compliant,
Yeah.
and but
Will she
sometimes
ask for food or drink, or you have to remind her?
we have to ask her, and she is very 2 or 3 spoonfuls.
Do you have difficulty her eating or drinking? She refuses?
She drinks and eats very little, and
Because one of the things we say to the parent, to the relatives, you need to find out what her best food,
yeah,
the favorite fruit.
yeah.
Sometimes you end giving them only ice cream because they wouldn't eat solid food as such.
Well,
So
I
you
find it
need,
difficult. She's in a lot of pain sometimes because she had arthritis. She had a knee replacement when she was healthy, and she complains of a lot of pain, and she's on painkillers. So when she's in pain, it's I find it emotionally hard, mentally, to cope with myself.
sometimes
So
antidepressant could help reduce the pain, and the pain exaggerating when they are depressed. So when they are terminally ill, they're more likely to become depressed, and you will not take it as depression. But depression comes through the physical symptoms: headaches, pains in the legs, pain in the muscles, um, no appetite, they don't want to eat, they want to drink.
Yeah.
So that could be a signpost to giving her antidepressant will improve the appetite, will improve the intake, will reduce the pain, and will make her a bit more happier. But that's sometimes overlooked by the carers. They wouldn't pick up, or the relatives. They don't see the depression. But that could be one point you need to look at.
So
Thank you.
one of the things which I would suggest is that because she is in pain, and I'm presuming that she's on some strong painkillers
Yes.
already been given,
Yeah.
opiates or
Yeah,
some
yeah.
sort of opiate.
Cardamom.
Yeah. So that will make her sick. So that's one of the side effects of the opiates, and that will make her off food. And more importantly, that one of the side effects is that she can get constipated, and constipation will make her sick and make her put off food as well. So we have to make sure that she's not constipated, because that's a very common presentation. So that's what we have to see. So laxatives, um, either you can use and so give her some fiber in her diet, lots of water, because dehydration will make her more constipated, and sometimes we have to use laxatives. Yeah, so like Sana and Movicol and Fibogel and these things. So if she's constipated, which is a very common thing, then she will not eat and drink, and she will feel sick, and she will get more confused with it. So constipation is a big major issue. So if you come to a geriatric ward or with a geriatrician, so we are actually quite obsessed with constipation. So that's because that's quite common and causes a lot of problems for us. So constipation can actually cause lots of problems.
Thank you.
You had a question for Sister
Sorry,
Roxana.
I was going to suggest that you yourself, you could have a carer's assessment
Yes, if you're the main carer.
if you're the main carers. Even if there's more than one of you, you could have an assessment, and they might be able to offer you emotional support, maybe some respite, maybe someone to sit with your mother. So you've got some time out.
Right.
So that could be it, or join a carers group.
Right.
So you're with similar-minded people going through the similar scenario you're going through.
And
And also, sorry, just the carer is not only social care, not
Yeah.
only social service. There is something called the Alzheimer's Disease Society. There is something called Forget Me Not Society. There is something called Age Concern.
Yeah.
They have support. They could come and support you, or
Right.
support her, or support both.
Thank you.
Just to follow on from that point,
Oh.
something, was there somebody else with a question?
No, it's fine, you can
Yeah.
ask.
It's just something, I've kind of been across this bridge many years ago, so I can relate to what brother's saying here. And sometimes it can be a lonely experience. If you're the main carer, you can have a large family, but it can be a lonely experience for the main carer. And like when you're talking about the assessment for the carer, not just the person that's actually in
that's
the
what I
need.
said.
It's not something culturally that we tap into a lot in the community. Some of us might do, but the majority, we don't tend to use those services, which could be really useful for us. Because sometimes just somebody to talk to who's been through a similar situation, they might give you practical tips. And just, somebody at the end of a phone line, they're not there as like carers for you, but they're just there to listen to you. And if they've walked across that bridge, walked that path before you, you can get so many tips from them.
There's day centers also, which usually people who can mobilize. Before we move to another question, I mentioned Dr. Mudassar mentioned that might be delirium. They might become more confused suddenly, and that's for all of you to know, because of physical illness, because they can't express themselves sometimes, or they can, but they feel embarrassed and they want to keep nagging you. You need to look into constipation, urinary tract infection, water infection. It could be toothache, it could be sinusitis, it could be backache, it could be joint pain. And you need, when you see the behavior changed, you need to really, you ask or you refer them to somebody who can assess them. And you will be amazed, from people with really tooth problem and they can't express it. And that could stop them eating as well. And because they don't want to go to the loo, especially when they are frail, they eat less. When they eat less, they become more constipated. So you have, vicious circle becoming like. Any more questions?
Can I just say one very quick point on your, just one final thing. You might have you done any advanced care planning? Have you done the respect form?
We've done that, yes.
Okay. And is it you updating it every year?
No.
So just for those of you who don't know, so we're very hot now on making sure that we have discussions in advance of crisis, of emergencies. So there's something called a respect form, RESPECT. It's an acronym, I can't remember what it stands for. Now that details your main diagnoses, but more importantly, it details your wishes. So it's a calm, collected environment where you speak with your doctor or geriatrician or whoever it may be, and you discuss exactly what you want at this point in your life when it comes to an emergency, or if it comes to a crisis. So it could be, for example, somebody who's really fed up of going to hospitals and they don't want to go to hospital anymore. So you write it on this form, and it doesn't necessarily, it's not set in stone. You can always change it. It's something that won't necessarily dictate what will happen, but will guide what will happen. So if there is an emergency, quite a severe infection, but the person's made it clear that they don't want to go to hospital anymore, then that will be detailed there. So if the paramedics are called, they pull out this form, and already they've had this discussion with whoever it may be. So if you've not had this discussion, go to your GP, book an appointment, and say, look, we want to talk about the respect form, or advanced care planning, where you detail the wishes of exactly what it is. It's replaced DNA CPR, so do not attempt resuscitation, because that was simply one question, and it's not good enough when, okay, we know they don't want to be resuscitated, but they're not about to have a cardiac arrest. So it's replaced that, and it's much more detailed, exactly what it is, and make sure you update it regularly, because your wishes change, as time goes by.
There's something called advance warning or advance declaration. We're not used to it in Muslim community. That we need to get used to it. That I write in advance that I don't want A, B, C, D done by going to hospital, being resourced, having morphine, whatever. I tell you, one of my patients, she was under the geriatricians, and she had advanced directive. She had the advanced directive that she doesn't want any investigations done or treatment. So when I was seeing her, we were giving her agreed for me to take some blood. So I took some blood and I had fingerprint from her. I hit my finger. So she ended, we didn't know what's wrong with her. And she went to the nursing home and she died after 4 months. So I was waiting to die after 4 months because I was. So this is one of the things you need to know. And the other one is the legal things that sort out your finance very quickly. I did actually myself sorted the finance in my family. And you can appoint attorney to look after your finance, and they could register the power of attorney to become like enduring power of attorney. Because if you don't have enduring power of attorney in one of your lasting power of attorney, you could end being referred to the court of protection, and every transaction they take 5%, and it costs like every time 5% of your wealth will go to Jeremy Hunt and his team.
Just be
Can I ask a
mindful
question
about
on
that.
this, on the power of attorney, lasting power of attorney. In our culture and communities, families don't really understand what this is. And as you say, when they get to the end, it's like then the children are like, who's taking over? What are we doing? Nobody knows. How do we encourage this conversation in our communities? Because again, no, I'll be fine. But actually, if it's given to somebody, say if it's one of the children or it could be a family member, it does make things clear.
Yeah,
so how do we encourage this conversation with our elders?
we invited to this
That's what we are trying to do today.
We invited to this seminar. We invited nearly 2,300 people. Some of them will never read the text. I will never read the email. And we had 20 who said they will come. Also, the 20 who wrote their names, not all of them came. But you can take the horse to the water, but you can't force him to drink. So that's
you actually have to talk to your own family. Like we've spoken to our parents. My husband spoke to his father. We've spoken to my mother, how she wants to do and what she wants to do. And really, you have to start with ourselves, and the rest, if people.
But they need to know. Even the terminology we don't know.
Some parents are open to discussion of, I think Dr. Veda had mentioned about dying, so they'll say, look, I want this in present, I want this for my janaza, etc. And some families look at you as if to say, are you trying to kill me? So this is the balance. I understand. You're right, it starts with your own families. But then you've got two sets of families that might be different. One really open, you can have a conversation with, and another guy looking at you thinking, are you trying to kill me? So I think, that, like you said, the core is, but how do, I suppose, being a young sort of person, and we've got younger people in this situation of caring for patients, how do we encourage them to have this conversation?
I mean, my tip would be that I would approach it in this way, that I mean, you are absolutely fine, and while they still have got full capacity, lasting power of attorney doesn't work. So it only works when they can't have the full capacity.
They register it.
So, no, even if they have registered and you've got it, and the person have the capacity, that overrides the lasting power of attorney. That doesn't work. So lasting power of attorney only comes into place when they lose their capacity.
But they should have power of attorney.
Yeah.
And then when you start, they're losing.
So you,
Muna now, she has a question.
So you can just to finish the point, you can just say that while you still can talk about yourself, it doesn't work. So it only will work when you become dementia or anything. Then only then it will help the kids. So you can discuss it in that.
One very quick one. The other thing we've done, because we've gone through this, is talking to people. I've been telling, this is what I've gone through, this is what we've had the information, and the LPA especially is very important, both finance and things. So
in
it's
Islam,
just by talking in community.
Yeah, the answer from Islam is the will. And in Islam, the Prophet ﷺ said, no one is a good Muslim until he sleeps for 3 nights. No one is accepted to be a good Muslim and he sleeps 3 nights without having a will under his pillow. So the will has to be written within 3 days from now, I'm telling you. Mona?
Roberta, one thing about the power of attorney. You said about the health one. Is it the same one?
No.
No.
So how do we apply for that one?
You just go
It's
to
not-
solicitor.
After the GP? Must we just
No, no,
go-
your solicitor. You go to
It's
solicitor.
not.
I was
It's
gonna
You don't quite do that
You
as
can
well.
do it online.
Yeah,
You can
online
actually do it online and get
Also
it
online.
registered with the Court of Protection.
And that what does that give me? That gives me the ability to decide what's the best in terms of health wise.
So if you go into hospital with a loved one and a doctor comes to you and says, we want to treat the chest infection, and you've had a conversation before with your mum, and your mum said, I don't want any more antibiotics. That's it. Just let nature take its course. The doctor will come to you. They will talk to you. They'll consider your wishes, and if it's something that makes sense, because the doctor has to understand what's in what we call the best interest of whoever it is. Now, best interest is defined in multiple ways. So it's not just physical needs, but also social, psychological,
But
spiritual.
if they are demented, that will not be valid.
Yeah. So how do you work out what's best for that person? They can't make a decision for themselves. How do you work it out? Now, if there's a conflict between you and the doctor, so they want one thing and you want another, then that becomes quite a tricky situation. Like, for example, you want to keep the parent at home, and the doctor, the care system feels actually it's not in the best interest of the patient to stay at home. So those are kind of conflicts where they arise. So if you've got lasting power of attorney for health or for welfare, then your decision is essentially the decision of the patient. So they can't override you in that sense.
Ashfa?
My brother and I, we wrote the power of attorney, and we
You
sent
wrote
it through.
for your family,
For my
you
father.
and your children.
No, my brother and I, we did one on behalf of my father.
No, your father has to. You applied
But
for
he,
it.
yeah, we applied. He
Yeah.
was still,
Yeah.
quite sane, able to make decisions, and so he was quite ill. But anyway, we sent it, and he was taking a long, long time as well. And I was teaching at Sunday school. I was called in on 13th of December, I think 2020, and 11 o'clock the paramedics arrived, and he was quite serious, and he was able to tell the paramedics that he doesn't want to go to the hospital. And I did try to, and later on when the second group came, they all came in and started. We were all family were there, and 2 o'clock they were all about to roll him out. I showed him the power of attorney, and said, no, that's not registered, that's not valid. But apparently, when they saw the paperwork and they saw the earlier ones who came at 11 o'clock, they written down that he did not want to go to the hospital, and they wrote it down. That one line was so important for us. All of us were there at 2 o'clock when he finally passed away. But that was important that he said that. And even though we filled the forms in, but it takes a long time to register.
It takes about six.
Yeah, it's a solicitor usually.
Yeah, we
they
did
will
it
do the power
online.
of attorney.
The other
I-
question was, the respect form, does it include whether you cremate or bury them?
It doesn't directly ask the question, but you can put whatever you want on the respect form.
Okay.
But there's no direct question for that. No.
Because that's
When-
another issue that some families are going through when there's, maybe they converted or something like that, and some families are, they maybe the
So they should put it on there.
yeah.
I went to see a patient on ward 17 in Solihull Hospital to assess her mental state. And on arrival, I found another guy coming to assess her. I said, who you are? He said, he is a solicitor. I said, why are you here? He said, I'm going to do the power of attorney because the patient wants to give all her money to the donkey sanctuary. So I said, hold on, let me see her first. And then you see her second. And she was totally gone, mentally very impaired. So I went out and said, look, save yourself time because her consent will not be valid. But they do call the solicitor, yeah. Any more questions?
Yeah. Roxana, when you said about the care, when you said 4 times a day, but is it half an hour each? Is that I understood that right?
It can be longer than half
Oh,
an
so
hour.
it could be longer.
It can be 45 minutes and up to an hour. It's dependent on the person's requirements.
But is the maximum 1 hour for 4 times a
It's
day?
difficult to say. It's all very much varied on what people's needs are. Somebody with Parkinson's will more than likely need a longer period than somebody with diabetes.
Yeah, brother.
For Roxana again, you were mentioning the assessment and for the person that has the care needs.
Yeah.
So let's say you've done your assessment and you say that they need 4 visits a day. This is the care package.
Yeah.
what's the lag time between actually getting the carers in and being assessed as having care needs on average?
Are you talking about if someone asks for this assessment from
Me.
home or from hospital?
Both. So say you're in a home situation.
Yeah. And you want a social work assessment?
Yeah, you've got the assessment.
Okay.
They've written their report,
Okay.
and it's stipulated they need this number of hours or whatever. What's the lag between actually?
The care calls.
No, what's the
When they
actual
start
lag between
coming.
when they
Oh,
start
start.
coming?
When they start coming.
Oh,
When
sorry,
the
sorry,
funding's
I didn't
released is what I'm
understand
saying.
that.
Yeah.
Well, if you're in hospital, your discharge would be based with your care being set up.
It's quicker through the hospital. That's what I found.
Absolutely.
Yeah.
Always.
Yeah.
If you want to see a social worker and you're out in the community,
God help you.
Actually,
it's
I-
quite hard, but it's possible.
I mean,
It is
I
possible.
can tell you from urgent care response team, we can actually start the initial, I think it's for 6 weeks or something, the initial emergency care package on the same day.
So that can be started straight away.
Straight on the
Pending
same
the,
day.
you know.
Yeah. So and then during that time, the social worker can come and assess and make the arrangement. So it can be actually quite
But
quick.
that's through the hospital,
That's
isn't it?
actually through the hospital settings.
Oh, no, actually, I'm
Is
talking
every-
about urgent care response community.
Okay,
You have that
But
experience?
that's NHS funded, isn't it? That's
Yeah.
not local authority.
No, but
Yeah,
no,
but
it
we're
is
working with them.
it is provided by the local authority. I don't know if where the funding is coming from. To be honest, I
Because
don't know.
the reason, so essentially the NHS wants to free up, and they said this is,
I know.
they want to free up beds because it's very expensive to keep in the hospital. And the only thing keeping the hospital is they've got no care package at home. So they fund that as a stopgap.
The NHS is funding that.
NHS, my understanding is NHS.
Yeah,
Yeah,
that's right.
it
And
could
then-
be NHS funding. I don't know
And
the
then,
answers.
and then in that 6 weeks, the social services are putting together the right
Remember, there's
package.
a type of funding where it's not the local authority that's funding the care package.
Yeah.
It's for certain conditions. It's the NHS, and that one doesn't require a contribution either. It's actually
Are we
100%
talking about continuing healthcare
yeah,
criteria?
continuing healthcare. Yeah,
Oh, that's
but that's not what you're talking about.
That's a different.
No, no.
Yeah, that's
So
different.
yeah, so
different.
I mean the social worker which are working in the hospital, they are still the same social workers which are in the community. So it's the same department.
Yes.
So NHS doesn't own the social workers in the hospital. So they're still under the same umbrella of
You
social
still work
workers.
for the council.
Yeah, for the council. So they're still working for the council. So that's why my understanding is that the GPs can actually get through the UCR. So you can refer the patient to UCR as well.
Yeah.
And they would do the same thing as what when we call them and do that.
That's
So
quite hard to
it's
get that funding though.
It's not a
yeah.
funding, it's actually free.
But
So
the
the first 6
funding
weeks.
you're talking about, it's very different.
Yeah.
It's when you end of life,
Yeah.
totally end of life. It's supposed to be less than 12 weeks, and that's when your social care, where your primary health care needs override your social care needs, and you get a free service, whether it's care in your own home or whether it's a nursing home placement. It'll be funded by the NHS. That's
Yes,
continuing healthcare criteria, and the person doesn't have to make a contribution.
It's a general question from Odessa.
Yeah.
It's just about, I mean, I always wanted to ask a palliative care doctor this question, but I think you're the next best thing to a palliative care doctor. So how is it, like emotionally and psychologically, how is it for you working with this kind of like patient group and the frail patients and people towards the end of their life? How do you cope with it yourself?
It's not easy, but it becomes easier with time. So the more experience and more things which you go through each time, it becomes easier. It becomes a little bit of part of your job. But it never becomes completely easy. So it's always hard. And my experience is that with our own community, these discussions are always very difficult because it's not easy. So with the English population, it's easier. When I say English population,
Which
I mean the
should
Christian
be, as
population.
Muslim, should be the other way around.
Yeah.
You expect that, yes, this is Qadarullah, this is the plan of Allah. I should give in and allow the medical and social care teams to do their best for the patient and let the patient go. I saw many Muslims, they keep grabbing, the doctors, come, you must, do this, do something about him. We don't want him to die, and while there is life, there is hope. And and could
Yeah.
stretch for 9 years.
Yeah.
I've seen one of them, a Muslim, but stretched for 9 years. So, and become vegetative state as well. Any
Yes.
more questions?
You know, when you said about the urgent care team, I've contacted them, and that's been for 2 weeks now, and they said they want to send someone for my mom
For
and 10 for the care as a care service. But until now, we have not received anything, and I keep chasing them daily, and they keep saying, "Oh, too busy. Leeds is a very big center, very big city. There's a lot of people who need support."
yeah, means to be honest, I can only tell you what my experience is.
Yeah. What
So
do I do maybe as an instead?
yeah,
Is there any other way?
so means my experience is that when we call them from hospital, Solihull is worse than Birmingham. It's way worse than Birmingham. So social worker, especially the social worker setup, is not as good as Birmingham. So we get the carers quite quickly in Birmingham, but when it comes to Solihull, we struggle.
Mine is in Leeds anyway. So it's
Oh, you
different
Leeds.
city. Yeah.
So Leeds, I can't tell you anything because
Yeah.
I don't know what their urgent care response team is doing.
How are you accessing the urgent care?
I'm calling the social services.
That's different, I think.
Yeah,
isn't it?
that's a different
to
thing.
this.
Okay.
So that's not urgent care response team. So
No,
that,
but they said they're sending the urgent care team because they said to allocate to a carer, it will take very long. And my mom, she deteriorated very fast, and they said we're going to send you an urgent care team now.
so it probably would be best if the GP does it rather than
So
you
shall I
calling
call
them
the
back.
GP
Go
instead?
through your GP. So that go through your mom's GP.
Yeah,
If the GP will call, that will happen quicker.
that will be fast in the process.
Yeah.
And the second thing you said about the sundowning syndrome.
Yeah.
When you said that the patient could, because that's what's happening exactly. She would sleep, she would wake up all night, and she would sleep all day.
Yeah.
So do we speak to the GP about that and get a medication sorted, or
Or a psychogeriatrician. So the old age psychiatrist. The thing is that there are some non-pharmacological things which we can do, as I mentioned. So keeping them busy, keeping them awake during the day, getting them out of the house because the light will change the circadian rhythm back to the normal.
okay,
Because they're not leaving the house, so they're not actually going into the sunlight,
yeah,
and that's one of the big issues.
okay,
So getting them out of the house, even if it is in the garden,
okay.
so getting them out in the house will help, so that we can get their circadian rhythm back into the normal physiology. And then we can use things like melatonin and other things, which are not sleeping tablets, but they can improve your sleep. So it's just to improve the sleep without the sleeping tablet. The problem is with sleeping tablets, if their already mobility is not good, then you give them the sleeping tablet, then they actually start falling. Yeah, they start falling. So that's the problem. So we don't like sleeping tablets,
Okay.
but in certain cases we have to use it, but we try not to.
And when you spoke about the falls and you said in terms of the safety, who would assess that? Who would decide as a family what to put in? Because no one yet has come as well to assess in terms of safety. What do? We bought her special bed. We've done everything as a family.
Yeah, so that shouldn't be.
Could you
It shouldn't
assess
be
that?
the case. It shouldn't be the case. I mean, the social worker, you should be getting all of these equipment from social services or from the OTs. So OTs, not the social workers. Yeah. So you should ask for OT assessment. So equipment you can get stick to start with.
Yeah, we bought her.
And then the frame.
Yeah,
and then it's a frame, and she's not walking at all. After that, the next step would be stand aids. So like standing in hoist, where they can actually use something to stand and transfer, or even a full hoist.
Okay.
But for that, they need to come and assess the house because it's a big thing. So they need to make sure that it can fit in the house and in the room where the bed is. I would already, is it a house or a bungalow where she lives in?
It's a house.
It's a house. So think about maybe setting up a downstairs living if it's not already there.
Yeah.
And if she's getting to that point, or if she's still walking, then maybe or putting in the stair lift.
The problem, she's refusing to use the frames. She's refusing.
Yeah,
she says, no, I don't need that. And she keeps pushing it away.
It is a problem.
And the minute she leaves it,
it is a problem. Yeah, this happens. Unfortunately, this is something which is common. Either they forget to use it, or they refuse to use it. So it's the therapist can come and they can probably assess, and I mean it's probably just keep on repeating and saying that it is for your health, for the help of your mobility. It might actually, when it becomes a habit, then she will keep on using it. It's just that making a habit is the difficult part, because there is no carry on. So you do an assessment, you do the therapy treatment, and the next time you come, the previous treatment is already gone because of the dementia. So you have to start again. So there is no carryover from the previous assessment because of the cognitive issues. So that's the problem. So that's unfortunately is something which does happen.
But there is
There
no
is,
way. Sorry. So there's no way to get things better in terms of like if they've got Alzheimer's. If there's any research that's shown to do something that's shown to improve rather than, because it looks like everything is deteriorating.
Yeah. So
there's nothing going this way.
No.
Forward.
So there's nothing unfortunately which will make it better. But there are things to slow down the decline.
Slow down the progress.
Yeah. So we can do so once the dementia starts, it just goes down this curve. This is the ideal, and that's what we want them to be on this curve. This is not what actually happens. So most of the time what we see is that they are going, and then there's something happens, a big dip, and then they get better, and this is now their new level. Then there's something happens, big dip, they get better, but not able to the level where they were. So we call it step ladder decline. And that's the most what we see. And we try to keep them on this smooth curve. It's difficult. So that's the aim, is to actually, rather than with these big dips happening, put them on this smooth curve.
There's only 2 minutes left for Maghrib, so we'll stop once Maghrib there. If there's any desperate, urgent question, then you can tell us to make use of the 2 minutes. Any other desperate question?
Okay, Roxana, if there's no one asking, I could ask. So in terms of the social care, so when you're saying to fill it, so because now we're providing a private carer, so a lady who comes into the house and she lives with her for most of the time. So, but the problem is now she's rejecting this person. Is there any way around it? Shall we?
Because she's not familiar to her, and she's not part of her setup.
And she only wants us as her children. She doesn't want anybody. She would call me. My brother would call me, so I could talk to her. So how do you work with that issue?
It's very difficult, really. It's very, very
difficult. She doesn't want anybody.
Because of course you're the most familiar people to her. You know, sometimes it's obviously not good to move your mom out of her own setting, because that's the setting that she remembers, understands the best. Rota, we have a rota for my mother, so
but they need to go to her.
And that's the thing now we're rotating. That is, like in the holidays, I'm going to go for the whole week, and then after that my brother is going. But the problem is, because we've all got kids and lives, it's very difficult to stay there for that period of time. For me, holidays it works because I could go and spend the time.
Sometimes the carer probably have no idea how to care for a demented person, because there's a lot of ways to distract and divert and change that subject and get them engaged in doing something else. And there's a lot of things they need to learn before they become EMI, elderly, mentally impaired patient carers. It's easy to care for somebody who's compos mentis, but it's not easy to care for demented. Even they reject the husband, the wife, the brothers, the sisters, the children. It depends on, how they develop. So that's important too. And then you need to look into underlying problems. Like I said, could be patient depressed, could be anxious, could be worried, could be in pain, there could be constipation, could be this, could be that.
So I could put I'm on the depression. We've asked the GP for the medication. They gave her depression tablets, but they also gave her the Alzheimer's tablets, and now they discharged her from the psychiatrist services because they said that's the maximum she could
If they haven't got anything else to offer.
I wouldn't look for too many medication. That's not an answer, honestly. Because
so she should not seek more medication.
No, the more medication, the more the problem.
Yeah, the least the better, because they could themselves cause the confusion and agitation.
One thing I would suggest and this is from the experience which I see from the patients, is that, I'm not suggesting you should do that, but one is that getting one of you take her with an annex. So like an
That's
annex.
what we're looking at.
Yeah. And the triangular living, where there's toilet, bed, chair. So they just live in this triangle, and that is quite easy to manage, and they actually manage that quite well. So we call it triangular living. So they just got 2-3 things which are very next to each other.
But she needs, I think, she reached the stage she needs toileting herself.
Oh no, that's
She
what I'm saying.
can't use the toilet herself.
No, that's
She
what I'm
needs
saying.
somebody to take her to.
So that can happen. So it's a commode,
Every 2 hours.
so there's a commode next to the bed, and the carers.
The
You can
carers
still
will
have
come to that
carers.
annex.
Yeah, so you can have the carers for that patient in the annex, and they can do they can empty the commodes and things. But it's like a commode next to the bed, so it's all just like in a small environment, in a very small space, so they don't have to move fast. So we call it like a triangle. So you probably have used this as well.
Yeah, Brother Sajid.
Yeah, saying, speaking to many colleagues over the last decades, in this situation, they say to me, Saj, we found a really great care home for my mum, and they feel that they've done a really good job, that they've gone over and above. We found a great care home for my mum. But you've got to think about who is the best, and if you were that mum, who's the best person or persons to provide the right care that's in the right social, culturally aware, all of those things. That's going to be somebody you can trust. It's not easy. So sometimes you wish that your parent was just like an English parent, would accept that. Think, oh yeah, my daughter's found me a great care home, it's just around the corner in Solihull. But it's not going to work for us. We have to think of other imaginative solutions.
We had difficulty finding residential and nursing homes for Muslims patients.
Yeah.
But I was surprised that people came from Hungary or Poland. They have all people's home for Polish people. That for
The
Hungary.
famous one in Birmingham is Alpanagar. I think that was the first one, near Central Mosque.
But that's what's the ceiling now for the residential home in Birmingham? The ceiling, the social service will pay up to.
Has anybody got more questions? Because we can come back after the slide if you want to carry
How
on.
much do we pay?
Can I just thank everybody?
620.
أشهد أن لا إله إلا الله أشهد أن لا إله إلا الله أشهد أن محمدا رسول الله أشهد أن محمدا رسول الله حي على الصلاة حي على